If he's totally relaxed, one arm is here, second arm is here, and baby is totally relaxing in the womb, enjoying his health. There's a smiling baby on the 3D, and if you make a video clip, that's the way it looks like. The fetus is going to smile over here and show different postures, opening the mouth, bringing his tongue outside, and showing all his attitude and behavior at the time of his examination. You can appreciate the twins here. One here, and the other baby is resting his face over the other brother or the sister twin. They have to be monochorionic, monoamniotic, or that's why they're so close to each other. Look at the other fetus is kissing his other fellow. And even you can see the multiple pregnancies, and you can appreciate the amnion, how many amnions are there, how many chorions are there. You can very easily appreciate and make the assessment. That is just one of the clips where you can appreciate the baby is busy with his own umbilical cord. He is putting the umbilical cord in his mouth and moving all the gestures. Certain anomalies which you can appreciate in the time of analysis. Look at the small cleft lip and palate on the left side of the fetus. That's eyes, the nose, and the upper lip, and there is a defect in the left half of the upper lip. That you can diagnose. The only idea is to give you the diagnosis and manage at the appropriate time. Last night we did the ultrasound. It was about, I think, 17-18 weeks pregnant lady. Primary gravida conceived after a long time, and unfortunately there was a multicystic structure on the posterior lateral aspect of the neck, and that was separated, multiloculated. It's basically cystic hygroma. You can appreciate this increased translucency with multiple loculations, and that was the video clip which was prepared, and there it is. That's the posterior part of the neck, and there's a loculated thick wall at the back of the neck over there. Similarly, again, this was a very recent addition. The lady who had basically severe micromelia, all the forelimbs were pretty small, the thorax was very small, and even the brain had got some anomalies. But the more important thing was the limbs, they were very small. If you look at the limb, that is the shoulder, there is the humerus, and a very small hand. Humerus radius are very small as compared to the rest of the parameters. The same child had another problem, and that was the fingers. If you look at the digits of the foot, instead of 5, this baby had got 4 digits. If you look at the markers and the 3D ultrasound as well. Basically, the problem was this boot-shaped ventricle, or this absence of corpus callosum, and directly impingement of the interhemispheric fissure of the third ventricle, which was dilated, pulled upwards, and the lateral ventricles, especially the posterior horn. Similarly, you can do this surface mode with the skeletal mode on it, and you can appreciate this entire vertebrae. You can count the number of ribs if there is any deficient or not. That is normal, and look at this spines coming down gradually, and there is minimal widening of the spines at the back of it. And she has got this spina bifida, and that you can appreciate on this 4D image, with this widening of this spinal vertebral canal at the lower end of lumbosacral spine level. Similarly, you can do this surface rendering and appreciate the fetal parts, like the count. You can count the fingers, you can see the feet, how they are placed and how they are looking, because the club foot deformity can be diagnosed very comfortably and very easily. Similarly, you can see the movements of this foot over there on 2D, and that's basically the 3D image over there. You can do the whole power Doppler NG of the whole of the fetal blood circulation. That's the heart. These are the carotids going upstairs. You can appreciate the aorta and the IVC downstairs. There's a new technology which has been introduced this year in this equipment, and that is the STIC technology. That is spatial temporal information correlation. Then you can appreciate the fetal heart, and the beauty of this is you can lower down the heart rate up to your requirement. That means you can lower down the heart rate up to 20, 30, whatever it is, because normally it's beating 140, and the idea is you can control the heartbeat, and you can see the valves, the septi, and the outflow tracts as well, how the blood is flowing outside. And if there's any small defect, you can diagnose it. You can do the fetal echocardiography. You can appreciate the chambers and the valves and the septum over there. These days is a very big word around these days, cord around neck. The babies have been delivered with cord around neck, but the only message the gynecology these days is if there is a cord around neck, please take care, because with a good biophysical profile which is going to be delivered by Dr. Daya, if there is acute sudden cessation of the fetal movements, and if somebody has reported as a cord around neck, please do give respect to that statement, because just possible the cord may be tight around the neck, and that very moment the fetus may be having some disturbance, irrespective of the normal amount of like 2 days back or 3 days back or maybe 1 day back. So if the biophysical profile is okay, but the cord around neck is there and sudden cessation of fetal movements, that means the baby needs some intervention, or there is a cord around neck, or there is other knot over. That's the way you can appreciate in 3D, and there is an altogether cord. This small portion is because of the shadowing of the spines in the center. And there's other picture of it. You can appreciate the full turn of the cord round, and the second is partly covering the neck as well. Regarding the gender or the genitalia, you can appreciate that's the thigh one side, there is second thigh, and there's the XY of the fetus. This again just collected last night, the lady who had a history of amenorrhea for the last about 9 weeks, and now she had come for the follow-up. She was spotting a bleeding. On the 2D, the sac was there, and also small chorionic cavity was there, but a small tiny fetal pole was there with a yolk sac, but no cord activity. We just did the 3D over there, and you can appreciate the beautiful episiotomy, this amniotic membrane, amniotic cavity, and a small part of the yolk sac, and a very tiny tinge pressing pulmonary cavity, which was a small fetal pole. And the confirmation, because yesterday as we discussed, there is a gross disparity between the fetal pole and the amniotic cavity. They have to be parallel to each other, because normally by 11 millimeter or 12 millimeter gestational sac, you appreciate the fetal pole, and the rate of growth is about 1 millimeter each. So they have to be comparatively of the same size. If abnormally big sac and a small fetal pole without cord activity, strongly suggested of missed abortion, no doubt about it. A few words about the gynae. Regarding the infertility patients, is arcuate uterus, septate uterus, or separate uterus. You can appreciate the septum, the height, the thickness, and the vascularity as well. Look at this uterus. You can measure the intercoronal distance and the height over there, and whether it's septate or subseptate. If it is less than 1.5, that's arcuate. If it is more than 1.5, it is subseptate uterus. That's the way. Normally, when 2D, whenever we do the 2D, we normally label it as a case of bicornuate uterus. Routinely, before this 3D, we used to label it as a bicornuate uterus. And the only answer was by histosalpingosonography, because there you can appreciate whether the cervix is separate, the body is separate, or whatever. Here you can appreciate one endometrial cavity here, one endometrial cavity here, and that's all. But look at this magic. It takes hardly a few seconds to construct the image and tell you it's a bicornuate uterus or a simple arcuate uterus. By measuring the distance and the height of, you can say it's a simple arcuate uterus. And there's a 3D construction, 4D construction, same patient over there. Look at this movements. Again, this is a lady who was pregnant and had a bile upper. That flow is outside, and that's again verified on the 3D image with reconstruction. Very small amount of blood is seen in the septum, but all these red colored vessels are outside. So it was a benign and simple cyst, and not a malignant cyst. There was a lady who had a history of a C-section, and now she was complaining of pain in lower abdomen. The report was that she has got only serosa left over the C-section, and the rest of the myometrium is torn out. On 3D construction, you can appreciate till about 5 millimeter myometrium is left over. The question was whether she needs surgery, and if she is left, she could be good and follow second pregnancy. This was a boy about 13 years who visited about 2 days back, and he had no testes anywhere. Done history, he was told he was surgery, but he didn't know it. But he was testicles which had moved. On this ultrasound with 3D, look at the small uterus which is appreciated over there, and a small over on the left side, because this girl basically is a boy, and he was developing a breast, but no menarche, because we're just about to start with that. Similarly, like follicular aspiration, you can see multiple follicles growing over there, and with the help of this intervention, you can appreciate in the real time your needle track over there. And look at the needle is coming down, and I'll just show you one big one. The needle goes in, right? This is a very bright echo, you can appreciate it, so that you can do the follicular aspiration or assist aspiration if it is small over there. Small parts in breast, it has got a wonderful effect in the sense it has got an extended view. With the help, you can scan the whole of the abdomen, move your probe from top to bottom, maybe 10 centimeter, maybe 20 centimeter, and leave it. Then it's going to scan the whole of the breast, whether you can see the skin, the retro, subcutaneous tissue, the glandular tissue, the retrieval tissue, underlying muscles, and even the ribs, all that can see in one scan. And from there you can see the relation of your mass. Does it have any skin adhesions? Does it have any underlying muscle problem or not? Look at this again, a mass over there. The skin is intact, the subcutaneous tissue is intact, the underlying retrieval tissue is intact. That means whatever the pathology is, it is within the glandular tissue. It doesn't have any involvement of the overlying skin or the underlying muscles, suggesting it's a benign lesion. Look at this again downstairs. That's malignant because of shadowing and involvement of the underlying muscles. Another software view is here, that you can have this longitudinal section and you can gradually move it and see the area of this interest. There's a papilloma with a dilated cystic, mammary duct, and that was suggestive of some malignancy. Look at the color Doppler showing rich blood flow in that area. The main advantage of, as I told you, intervention is 3D in superficial parts, and one of them is the breast. On 2D you think you are in the mass, but you are not. But if you do the 3D ultrasound guided procedures, you are seeing in the mass, and if you rotate your probe, again you are in the mass, and that's I'm going to demonstrate it here. Look at the needle there, look at the needle here, and that's our real time. So you're right here in the center of the mass, you can't miss it. Similarly, if there are long areas of problems, look at this patient who had a long area history of suggested DVT, for which the lady came over there for 28 years, but she was painful leg. We did the ultrasound. There's a large hematoma formation which is about 15 centimeters. You don't have to measure it because the scale is already on the top of it. So from there you can assess how much length of it is, and in one go you can take the whole of the measurements irrespective. Similarly in thyroid, from one side to the other you can move and see the number of defects, one or two, and measure the parts. This is a very strange case, very high lady who had a history of surgery, appendectomy, and now she was complaining more pain as compared to before surgery. Look at this, a small defect about 8 millimeter in the anterior abdominal wall at the site of the operation. From there the gut loops are moving out, right before the skin. The skin was intact, but she was painful on cuffing, standing and standing up. So there was still a hernia over there. So that was operated and she recovered. Last one or two slides. Similarly in eye, you can appreciate this 3D, the whole of the eye. The idea is to locate the foreign body, relationship with the adjacent structure, so you can do the proper management and removal. There is also facility of the volume measurement. If there is a breast lesion or a fibroid, you can measure the exact volume and give it to the surgeon and gynecologist so they can do the surgery accordingly. Interventional, if there is a small amount of fluid anywhere which is difficult to aspirate on 2D, sometimes you can introduce the needle. This is basically a pleural effusion. There you can appreciate the skin and this pleura, and needle you can appreciate right in the center of it. The diagnostic aspiration, because the patient history of little cough, an X-ray was normal, ultrasound showed a small amount of pleural effusion. It turned out to be tuberculosis. So I think with the help of this 3D, 4D technique, you can appreciate the things better, do some good service to this society. And my take-home message is, the advantages are, it's a multi-planar information, it's surface scanning available, volume measurements you can do it, there is the fetal behavior, you can appreciate that, inter-colleague consultation, you can send the image because the DICOM facility available, and there is electron transmission data facility available. Thank you very much for hearing me.
Thank you, Professor Dr. Safdar Ali Malik. Any questions on 3D, 4D ultrasound?
Indian Federation of Ultrasound in Medicine and Biology. The topic for her is role of TVS in genital tuberculosis. Dr. Yashodhara from India, please.
I am not going to talk all. I am going to restrict my talk to a chronic infection, that is, one of them is a tuberculosis. Although I want to make it very clear in the beginning, ultrasound doesn't give you a direct evidence to diagnose genital tuberculosis, but it gives you a lot, because before we were not doing this sonography, we were not able to diagnose many of the cases what is the cause of many of the pelvic problems in these women. Since we started doing this imaging, we started diagnosing more and more, and we were started treating also. That is the advantage of it. People were said you have got nothing, you have got no problem, and then when we underwent the sonography, then only the problem could be think it off and then further investigated, proved, sometimes not proved, because it is very difficult to investigate and to confirm, to say that it is a genital tuberculosis. But sometimes it is empirical